Welcome everyone to the April meeting of the IPV Task Force. I will be admitting people and will be the ad person. What we found is if you can turn off your video cameras while you're not speaking, that will help with the recording. And we definitely want to record this one with such great speakers. So if there's any admin issues, shoot a direct message to me in the chat, or I think everyone has my cell phone. If anyone can't get let in, also let me know. I'll put my phone number in the chat. So with that, I turn the meeting over to Angela.
Well, I just want to thank Katherine, as always, for always help supporting the network and taking care of all the technical aspects of as well as the and promotional aspects of today. And I concur that we have such a fantastic lineup of speakers today. I do want to link also the speakers to the special topical issue in the Journal of Head Trauma Rehabilitation that I had the honor of co-editing with Valera, and they are going to be talking about their papers that they contributed to this special issue. So we have three presentations, one on neural correlates of traumatic brain injury in women with a history of IPV and structural and functional connectivity neuroimaging study by Dr. Catherine Fortier and Emma Brown. Our next presentation after that is a longitudinal analysis of persistent post-concussion symptoms, probable traumatic brain injury and intimate partner violence among perpetrators. And this will be presented by Dr. Galina Portnoy. And early, there will be a presentation by Lyn Turkstra on the prevalence and perception of intimate partner violence related to traumatic brain injury. So I am going to start by introducing our first two speakers. Dr. Catherine Fortier is the Deputy Director of the Translational Research Center for Traumatic Brain Injury and Stress Disorders, the National Network for Traumatic Brain Injury at the VA Boston Healthcare System. And she's an assistant professor at Harvard Medical School. She's a clinical and research neuropsychologist and has developed a validated assessment for brain injury in military settings and for women with a history of IPV. And she's going to be talking about that. And also joined by Emma Brown, who's a senior imaging data analyst at the Research for Veterans Center and the Translational Research Center for Traumatic Brain Injury and Stress Disorders, the National Network for Traumatic Brain Injury at the VA Boston Healthcare System. She has extensive neuroimaging processing experience as an investigated brain changes related to PTSD and traumatic brain injury in post 9/11 veterans. So without further ado, looking forward to your presentation.
Thank you so much for inviting us, Angela. We really appreciate it. So as Angela already mentioned, Emma and I are from TRAX. TRAX is at VA Boston. So it's a TBI National Network Research Center that's funded by VA RR&D. Our primary site, as we mentioned, is in Boston. We have a secondary site actually in Houston, Texas. And our goal is really to conduct multidisciplinary clinical research aimed at understanding what we consider to be the very complex condition that occurs when TBI and trauma or post-traumatic stress disorder occur at the same time. And we do this work with veterans who have served in Iraq and Afghanistan, but we feel that what we have learned from studying combat trauma and the co-occurrence of physical and emotional injuries can really be applied to IPV as well. Okay, so for this study, we have partnered with our great colleagues at the Women's Health Science Division at the National Center at VA Boston, as well as University of Missouri, St. Louis, and Washington University. And we have tried to apply our comprehensive approach to the study of brain injury in veterans to the study of brain injury in IPV in females who have a positive history for IPV and also screen positive for PTSD based on the PCL, the PTSD checklist for DSM-5. And the methods for our work were, again, to just apply the comprehensive TRACS approach, which includes assessments in multiple domains. It includes medical and blood-based biomarkers, structural and functional imaging that Emma will discuss in a few minutes, extensive clinical diagnostic interviews, neuropsychological or cognitive assessment, and then self-report measures of psychological and psychosocial functioning. All of this takes quite a long time for the women to complete. It takes about 12 hours over usually 2 days of assessment down in St. Louis. So I'll skip the neuroimaging methods for now. But what I'd like to highlight as part of the methods that we used in our study is the adaptation of our military assessment of traumatic brain injury for women who've experienced intimate partner violence. So for all the reasons that I mentioned in terms of the co-occurring physical and psychological trauma that occurs in military settings, obviously this can apply very directly to IPV as well. Importantly, the battle not only assesses for those particular types of injuries, but also takes a lifespan approach. So we also assess for injuries, brain injuries across the entire lifespan. And so we conducted a validity study that compared the battle for intimate partner violence to that, sorry, I'm getting a pop-up here, to the Ohio State method of identifying TBI. And that paper was also recently published in the Journal of Head Trauma and Rehabilitation, although it wasn't part of this special issue. So that's what you see here. And I just wanted to give a little bit of context because I know so many people on this call know so much about the assessment of head injury in IPV. So obviously there's lots of different approaches to TBI assessment, and these range really from screening, in which you want to capture all possible injuries, all the way up to the battle, which we would consider a much more specific and time-intensive approach to the assessment of TBI. So it tries to move beyond a typical clinical interview and in a semi-structured and forensic manner, really get very specific about the diagnosis of traumatic brain injury. Injuries are assessed by IPV relationship, in which the women rank ordered the injuries from the most violent relationship first. And what I mean when I call it a forensic interview is that we are disentangling the physical and psychological symptoms as best possible, which is a very challenging task. To do this, we focus on the physical injury and try to really ground the women participants in a medical framework and minimize emotional triggers. And then we try to establish a timeline of injury using structured cueing provided in the interview, and to check that timeline for consistency and collateral information. And we're doing all of this to identify the presence and duration of the acute markers of brain injury, altered mental status, post-traumatic amnesia, and loss of consciousness to try to improve our diagnostic accuracy. And the battle also tries to capture anoxic injury, which we understand is very common and shouldn't be ignored when you're considering brain injury and IPV, and not only assess for the presence of strangulation, but also loss of consciousness secondary to strangulation. And in addition to repetitive subconcussive injury, so injuries that are not meeting diagnostic classification for TBI, but may still be causing physical damage. So this just shows a little bit more the severity of injuries along that scale. So we start with sort of the lowest threshold of injury, which would be any blow to the head. So any report of blunt force impact to the head secondary to IPV, regardless of force and severity. And about 94% of our sample reported injuries, of the women reported injuries of this type. And then when we specified further the injuries that were potentially severe enough to cause disruption of consciousness or memory, 77% of the women in our sample reported this level of injury. And then when we were using the battle semi-structured interview to assess for, diagnostic criteria for TBI, meaning meeting the standard of definition for presence and duration of altered mental status, post-traumatic amnesia, or loss of consciousness, 35%, or a little over 1/3 of the women in our sample reported a TBI, an injury that met that diagnostic classification for TBI. So I realized, Emma, that I'm having trouble advancing the slides, that I skipped over our methods. I'm going to see if I can go back. Oh, I can use the arrows now. Great. Okay. So before Emma describes our imaging results, I did skip over a description of the sample when I was advancing the slides. But for this study, in partnership with the National Center in St. Louis, we tried to apply our approach from the TRACS military sample to women who experienced IPV. And again, it was that 12-hour assessment over 2 days in all of the areas I described. But did I still miss? Maybe, do you have it, Emma, the description of the actual participants? Was I okay? I'll let you jump in, and you think so I guess we could ask if there's any questions on the sample before Emma describes our imaging results. So again, the women all screened positive for PTSD, all reported a history of IPV. And then of those women that we assessed, Emma will describe those of them that were eligible for the MRI and what we found with the MRI findings.
Kate, there was a question about women of color being recruited.
So there wasn't a particular, so the women, I can give you a little bit more information on the sample before we get started. There wasn't a particular targeting of women of color, but the sample was very representative, and I can pull up that table while Emma's talking. The primary recruitment involved flyering multiple shelters, as well as reaching out to various community partners of our colleagues down at University of Missouri. So I can take a look up for that specific table while Emma gets started with these results.
Okay. I'm able to advance them. I might just have to share my slides. Okay, thank you. Everyone can see that okay?
Looks good.
Okay, great, thank you. So we're really excited to discuss this pilot study that we recently published as part of the special issue of the Journal of Head Trauma Rehabilitation issue on brain injury and intimate partner violence. So we know that the impacts of traumatic brain injury on brain structure and function have been well characterized in other contexts, including sports industry injury and what we mostly see in tracks, military blast exposure, deployment-related TBI. And these can further impact cognition and functional outcomes. But there's really limited research on IPV-related head injuries, and even less so on their impacts on brain structure and function. And we also know from the literature that trauma or PTSD can further exacerbate these neural changes. So to address this gap in the literature, our study goals were primarily to understand the neural consequences of TBI in IPV survivors via macrostructural integrity, here indexed by cortical thickness, as well as functional connectivity using seed-based methods. And secondly, we sought to investigate whether IPV-related TBI impacts the neurological representation, whether a TBI secondary to IPV versus a TBI of other etiologies can impact these results. So as Kate had gone over previously, community dwelling women were screened and recruited if they screened positive for intimate partner violence, as well as PTSD on the PCL5. And participants who completed both the clinical assessment and the MRI were ultimately included in this sample, resulting in about 45 subjects. Now, prior neuroimaging studies of intimate partner violence have demonstrated alterations in these regions associated with these fight or flight. So we think of the insula, the amygdala, prefrontal cortex, supramarginal gyrus. No prior study to our knowledge has examined both brain structure and functional differences associated with TBI compared to intimate partner violence alone or IPV-related TBI compared to other TBI etiologies. So using the FreeSurfer software suite, subjects were processed through an automated reconstruction pipeline to conduct surface-based analyses of cortical thickness. And then resting state functional scans were processed using a standard pipeline, including concatenation of scans, motion correction, bandpass filtering. So for seed-based analyses, seed regions were derived from parcellations of the cortex. First, the bilateral superior third of the isthmus of the cingulate was used, as the connectivity among regions within the default mode network, or the DMN, has been reliably detected and well characterized in studies of other clinical phenomenon. And the regions that make up these networks in the default mode are highly connected to additional extra network regions, which may make them potentially sensitive to changes with disease. And prior studies in individuals with PTSD and TBI, even within TRACS, we have demonstrated default mode network connectivity can be useful for understanding pathophysiology that is most likely to affect those with a history of intimate partner violence. Secondly, the bilateral amygdala were used as seed regions, as amygdalofrontal connectivity alterations are often associated with response to trauma-related or emotionally charged stimuli. So the partial correlation to each of these seeds was used in group level analyses, and we examined group differences in cortical thickness and functional connectivity to the seed regions over the whole cortex using a whole brain vertex-wise general linear model approach. So the first analysis was conducted by lifetime TBI as determined by meeting criteria on the battle for IPV, followed by TBI etiology within the TBI group, whether the lifetime TBI was intimate partner violence related or otherwise. So in our first analysis by TBI history, we observed significant differences in cortical thickness by TBI, where IPV survivors with a lifetime history of TBI exhibited lower cortical thickness in the left superior frontal and precentral gyri compared to those without a history of TBI. And the average thickness was extracted from these regions in blue that survived correction for multiple comparisons with a Monte Carlo simulation approach. And although there were observed differences, main effects of age, the results were largely insensitive to the inclusion of PTSD symptom severity and age. So therefore, neither covariate was used in the final model, as they would potentially underpower this already relatively small sample. And secondly, we observed alterations in default mode network connectivity within the IPV TBI group, where IPV survivors with a lifetime history of TBI exhibited greater connectivity bilaterally between the posterior cingulate seed and the superior parietal cortices. TBI individuals also had lower connectivity between the cingulate seed and the frontal pole, which is consistent with previous IPV research that has found alterations in prefrontal circuitry. No region survived correction for multiple comparisons in the amygdala connectivity analyses. And again, these results were also largely insensitive to the inclusion of age and PTSD symptom severity. I'm sorry, I just wanted to look at the chat here. So for our second part of our analyses by TBI etiology, within the TBI group, those who endorsed a TBI secondary to intimate partner violence exhibited lower cortical thickness in the right paracentral gyrus. And again, although there was a main effect of age in this region, an assessment of covariance revealed that neither age nor PTSD severity accounted for significant variance in these differences of cortical thickness. And so the results presented here demonstrate a critical start to an area that has received little attention in TBI research to date. Alterations in both brain structure and function suggest a possible IPV-related neural mechanism underlying neural changes. And although our sample size and it being cross-sectional is a limitation. Our results indicate that these methods are robust, and future research with larger populations, perhaps longitudinally, will be necessary to validate these findings. We do hope to collect more data so as to examine repetitive subconcussive head injuries and PTSD severity in a more nuanced approach. But these methods could also be a valuable endpoint for assessing impacts of treatment that target IPV and TBI. Thank you. If there's any questions, Kate and I are happy to answer.
Yeah, that was a great presentation. I'm wondering whether we could use the chat because we do have two other speakers but in order to deal while we're getting ready for Dr. Portnoy's talk. But thank you so much for that cutting edge presentation on so many levels. So the next speaker I'd like to introduce is Dr. Galina Portnoy, who's an assistant professor in the Department of Psychiatry, the Yale School of Medicine, and she's a psychologist at the VA Connecticut Healthcare System. She directs the Intimate Partner Violence Center for Innovation and Research, a national VA IPV innovation hub. Dr. Portnoy's program of research includes intimate partner violence, detection, prevention, and treatment, and the intersecting areas of trauma, resilience, and implementation of best practices in medical settings. Her current research focuses on bidirectional IPV screening and IPV perpetration treatment development and strategies for disseminating and implementing empirically supported IPV practices for veterans. So looking forward to your presentation.
Thanks for having me. I'm trying to figure out how to both be able to see everyone and my slides, but I don't think I'll be successful in that. So bear with me for a sec. What do y'all see? Do you see the slides or do you see the ones from like the PowerPoint?
You just need to put it into presenter mode.
It is, but I'm worried my monitors got flipped. So I'm wondering, are you seeing the one with my cursor or are you seeing one without my cursor?
I see your cursor and we see the slides, all the slides along the left, which is fine. We can roll with that, whatever.
Yeah, we can roll with that.
Okay, sounds good. Let's see if it'll work. Okay, so hi everyone. I'll be presenting today on head injury and intimate partner violence perpetration among veterans. I am coming to you from the VA in Connecticut. So I am actually the director of the Intimate Partner Violence Center for Innovation and Research here. It's a national intimate partner violence assistance program innovation hub located in the Connecticut VA healthcare system. And our mission is really to develop, disseminate, implement, and evaluate innovative, high-quality, veteran-centered, and trauma-informed practices for intimate partner violence detection, prevention, and treatment. And we're really particularly focused on intimate partner violence perpetration and bidirectional IPV. So that's sort of where this project grew out of. We have two main cores in our center. One is the Innovation and Implementation core, where we focus on developing innovative IPV practices for veterans and strengthening current programming, and the research core focused on informing intimate partner violence policy and practice through research. So I'll tell you a little bit about the background for the study. It really originated from the understanding that recently returning veterans are much more likely to experience and survive traumatic brain injuries than previous generations from previous wars and conflicts. And in fact, blast-related TBIs are considered the signature injury of the post-9/11 conflicts, and they represent the most common injury among post-9/11 service members and veterans. There we go. And post-9/11 veterans also experience high rates of PTSD and substance use. And these risk factors may lead to heightened perpetration of intimate partner violence, with up to 60% of post-9/11 veterans reporting intimate partner violence perpetration. There are many reasons these rates are so high, and potentially, I'm sorry, I am losing my slides. It's all right, we'll roll with it. So there's a lot of reasons why these rates might be so high, and possibly related to head injury. So some of the symptoms following TBI can result in a lot of challenges related to interpersonal relationships, such as cognitive deficits, like memory and concentration problems. Also, affective issues such as depression or anxiety, irritability. We also see a lot of behavioral difficulties like sleep disturbances and agitation, and physical problems like headaches and chronic pain, and a lot of adverse social functioning, especially in the areas of relationship difficulties and aggressive behavior. It's really specifically these affective and behavioral difficulties like irritability and verbal aggression that have been shown to develop or increase following acute TBI and persist long-term, thereby really interfering with one's relationships and interpersonal functioning. Persistent post-concussion symptoms can continue well beyond the period of acute head injury, and these include symptoms such as headaches, irritability, difficulty concentrating, memory problems, and sleep disturbances. And as you can imagine, these symptoms have a unique impact on psychosocial and interpersonal domains. So we really thought that understanding this unique role with these symptoms can play in IPV perpetration among veterans was essential, particularly due to the lingering impact of persistent post-concussion symptoms and the role that they can have potentially on longer-term relationship functioning and intimate partner violence perpetration more specifically. So we designed this longitudinal study to examine the associations between probable traumatic brain injury, persistent post-concussion symptoms, and intimate partner violence perpetration. We hypothesized that TBI and persistent post-concussion symptoms reported at baseline would be positively associated with intimate partner violence perpetration at follow-up, controlling for demographic characteristics and common predictors of intimate partner violence perpetration, such as PTSD and substance use. We included veterans with non-missing data on the main measures, resulting in a sample of 1,150 veterans at baseline and 827 at follow-up. We used a zero inflated negative binomial regression to examine whether baseline TBI and persistent post-concussion symptoms predicted IPV perpetration at follow-up, controlling for these demographic and common predictors of intimate partner violence. We found that almost half of the veterans in the sample reported intimate partner violence perpetration, and also probable TBI and higher persistent post-concussion symptoms were associated with both the occurrence of intimate partner violence perpetration, so whether or not IPV perpetration occurred, and more frequent intimate partner violence perpetration. Moreover, while TBI and persistent post-concussion symptoms were both associated with IPV perpetration, it was really only the persistent post-concussion symptoms that significantly predicted IPV perpetration after controlling for common predictors of IPV. So some implications that our findings have. One finding that persistent post-concussion symptoms are uniquely and significantly associated with IPV perpetration, and this has important clinical implications. Given that post 9/11 veterans have elevated risk of head injury, our findings really underscore the importance of increased assessment of PPCS in clinical settings, and that increased assessment and treatment of persistent post-concussion symptoms can potentially play a really important role in decreasing intimate partner violence perpetration and perhaps even increasing relationship functioning. So I just wanted here to put the citation and a screenshot of the article. You can read more about the specifics of the study in our paper that was recently published in the IPV and head injury special issue of the Journal of Head Trauma Rehabilitation. Let me exit this so that we can talk and take questions if you have them.
Yeah, thank you so much for that presentation. It really adds another perspective in terms of the kind of work that we're focused on in terms of the perpetrator side. So just maybe we have a minute for one question while Dr. Turkstra might be loading her talk.
I just wanted to jump in, Katherine, because as we've transitioned away from post-concussion syndrome to symptoms, I'm finding a lot of support with that, but depending on which part of the country or Canada versus US, you're having different terms. So I was wondering if the VA has locked down on that is the term, and then we'll see it, filter out into the community. I'm all behind the symptoms over the syndrome.
That's really helpful feedback. I appreciate that. I'm not well versed in the field of head injury, so it's really helpful for me to hear, especially what folks that are experiencing head injury prefer. I think that's really important to take into consideration, and certainly I think makes a lot more sense to talk about symptoms versus a syndrome. So it's certainly what I will continue to use in my research, and really do appreciate hearing what the preferences are.
I came back from Rowan's Law in 2019 and approached the group, which I think was probably about 6,000 women at that time, really expecting that they would feel like the rug was pulled out from under their feet, that was a syndrome, and now it was being downgraded to a symptom. But overall, universally, I was really surprised that everyone found it a much more optimistic term, and much more, there were things to do and doctors to see, and were much more encouraged to seek out medical care when it ended with symptom. I've seen a couple of different versions, whether it's persistent or prolonged, and whether the post is in there or not. So I don't think anybody's locked in on anything yet, but would be great if the VA did. So thank you. I appreciate the terms, and it was a lovely slide.
Yeah, it was. Thank you. Okay, well, I'd like to now introduce our next speaker. Dr. Lyn Turkstra is a professor at the School of Rehabilitation Science at McMaster University, head of the graduate program in speech language pathology, and a faculty member of the McMaster Neuroscience graduate program. Her research focuses on understanding social communication challenges in adolescents and adults with acquired brain injury, and developing intervention strategies that will optimize long-term social outcomes. And she most recently is the recipient of the prestigious Moody Prize for contributions to traumatic brain injury research. So without further ado, Lyn.
Thank you, Angela, from another Moody Prize winner. That's how we know it's prestigious, because Angela and I both got it. Katherine, I just want to follow up on your question about the VA. A VA colleague of mine said, when you've seen one VA, you've seen one VA. So the idea that the VA would land on any particular terminology across the entire system is probably not going to happen. I work mostly with the San Antonio VA, and we use PCS, but I think we use it as syndrome, not symptom. So thanks for sharing that. Hopefully you can see, Angela, my screen showing okay?
Yes, I can see it, yeah.
Thank you very much. So it's great to have the opportunity to share a bit about this study. So I come to this from the perspective of cognitive rehabilitation. So most of my work is in treatment, and my interest has been making sure that we identify people with TBI in settings where intimate partner violence is indicated, so that it's mostly women appreciate that there's something that can be done about their cognitive challenges, and also increasing recognition of IPV in settings where people with brain injury typically are found. And that's the PIVOT study that I'm going to talk about today. So the PIVOT study and this whole initiative on IPV in different settings is really headed up by orthopedic surgeon, now chair of medicine, Mohit Bhandari, and Sheila Sprague is a neuropsychologist. And Sheila and Mohit have been very interested in IPV for almost a decade now, because physical IPV is the single greatest predictor of domestic homicide, and is a predictor of domestic homicide, and the single greatest predictor is a previous fracture. So a lot of people with IPV are showing up in fracture clinic. So they have endeavored over the years to make sure that surgeons in fracture clinic and all frontline personnel are educated about IPV. And there's a whole IPV Educate program that I have a link to on the last slide if you're interested. So they conducted a couple of studies in the past looking at the prevalence of people self-reporting IPV in different fracture clinics. They have a multinational study that was published in the Lancet, for example, and we basically used their methods. And so the study was led by Brandon Manoranjan, who currently is a fellow in neurosurgery, but was an MD PhD student at the time. The objectives of this pivot study were to determine lifetime and 12-month prevalence of IPV and IPV-related mild TBI among women who were coming to initially the emergency room, but then were referred to a community clinic for evaluation of suspected mild TBI. So this is really a unique group. So these are women who come into the ER, there's some suspicion of mild TBI, and then there was a pilot project to refer them to rehab right away. And so we took the first, well, as you'll see, the first consecutive admissions in that community clinic. And a secondary purpose was to see how much these women knew about TBI, just to see if there was a need for future training. So participants were patients who came to the emergency room, got referred to the community clinic, self-identified as women, and had self-reported age of at least 18. I have to say, I was just looking back in the data and I don't have the race data here. I'm sure we have it. I'm happy to get that if anyone's interested. We used a regular demographics questionnaire, the direct method of IPV screening, and you're probably familiar with that, and I'll show it in a sec. Brandon developed a TBI awareness questionnaire, and then we used the standard neurobehavioral symptom inventory that's commonly used in mild TBI. This is the direct method. Basically, you ask people in the past year if they've been physically, emotionally, sexually abused by an intimate partner. And this has been shown in previous studies by this group, by our group and others, to be a valid way of getting information. Okay, so this was our recruitment. So we screened 97 people, ended up with a sample of 50. And I just have this slide to say our recruitment rate was 68.5%. And I'm going to come back to that in a minute. So of the 50 people who participated, 46 reported their age, and they were around 46. 32 of them reported their relationship status, and 2/3 of those were in relationships, married, engaged, or dating. And I think that's really important when it comes to the status of the person who sustained the TBI and IPV. So these were the results. In the last year, 13 out of 50 women reported IPV. So mostly emotional abuse, but 3 physical abuse. And we asked them if it was never, sometimes, or often. So these are the results for never, sometimes, or often. And I think that this statistic stands alone as a really alarming statistic because no one ever asks about IPV in brain injury rehabilitation. So it was really, I think, informative for the staff to recognize that there were these women among them who might be discharged out of rehabilitation back into a violent situation. In terms of lifetime, it was almost half of the women reported some kind of IPV in their lifetime, including 12 who reported physical abuse. As I mentioned, most were still in that relationship, and the most common perpetrator was the spouse. There were 4 reported at a time that they thought they needed to go to the ER, but didn't go because they were stopped by or afraid of partner, which told us that we can't wait for a medical setting to do increased education and awareness. And 5 reported having been choked by a partner in the past year, 8 in their lifetime, just showing that we need to make sure we include strangulation when we talk about IPV, strangulation attempts. From the neurobehavioral symptom inventory, the women who reported a history of IPV had higher scores. So they're only significantly higher for the total score, but they were slightly higher all the way through, which supports the idea that this combination of IPV and TBI might present a more complex clinical scenario than either alone. I just want to take a minute to mention our second study that I know I've presented previously, but some of you might have heard of. And I'm mentioning it because I think the statistics are similar in some ways. So this was a study that we did in the fracture clinic to see how often how many women reported IPV and or brain injury in the last year or lifetime, because we were trying to figure out whether the fracture clinic might be a place to capture women with IPV and TBI who weren't being seen in other services. So same kind of criteria. We were next to the Barton Street jail. So this is kind of a rough area. I'm saying that just to say that I think our sample, although broadly representative of level 1 trauma centers, does have a bit of a sample bias toward people who live in higher risk environments. Same kind of tools. We didn't know about the battle, so we used the Ohio State methods, and our recruitment rate was 56%. So I'm mentioning this like I did for the first study to say, I think we're very concerned about who we're missing. People declined to participate before they knew what the study was about. So I don't think it's that people don't want to disclose IPV. I just feel that we need better ways to engage women in this research so that we can really capture the full scope of the problem. For us, it was partly because it was a super crowded waiting room and people didn't want to be in the study. But I think there's lots of reasons to discuss. So what we found in a nutshell is that having TBI didn't increase your risk of IPV or vice versa. We found a shocking half of the women in our study out of 144 who participated had a lifetime history of TBI, or probable TBI because it's by self-report. Also never addressed in the fracture clinic at all by any staff. And then we found the same number as Mohit and Sheila had found previously, about a quarter of women reporting IPV who are coming to the fracture clinic. We found again elevated neurobehavioral symptom inventory scores when people had both compared to either, but mostly it was people with TBI. As a result of that, we've created some videos for educating fracture clinic staff and other frontline staff about the likelihood of TBI and IPV when you're working with patients who are coming in presenting with a fracture. And that includes an infographic with some tips for clinic about how to manage a patient who might have some cognitive impairments in their clinic. Yes, I'm happy to put the link in the chat. And that's it for me. Thank you. And yes, I totally agree about sex and race. And as I said, I hope we have race data, and I can get that.
Well, thank you, Lyn, for sharing not only the paper in the special issue, but also this work that you've done with the orthopedic surgeons and orthopedics. It gives a really important perspective. And I realize there's a whole lot of research on IPV and orthopedics out there. So, and you brought the brain injury into that, which is fantastic. So I'm thankful that also Dr. Katherine Fortier is also with us. I know she's got a VA meeting probably at the same time, but perhaps we can open it up for questions to Lyn and also Katherine in terms of questions on the presentation. And by the way, if somebody missed it, in case, I don't want to miss it, but there was a big announcement about an award that both Katherine Snedaker and Valera received. So I don't see it anymore in the chat, but congratulations. Women Making History Award. So this is on behalf of safeliving.org. So thank you very much for your innovation, research, and social entrepreneurship related to concussion and domestic intimate partner violence. So congratulations.
Thank you very much, Angela. And Nat has a question.
Thank you. I was going to ask, did you include maxillofacial surgeons and orthopedic surgeons?
Thanks for asking that. I just put an answer in the chat. Not yes for some maxillofacial surgeons, but plastics is a separate clinic. So we didn't include plastic surgery.
Thank you. I wasn't thinking about plastic surgery as much as like a Lefort or the dislocation of a temporal mandibular joint. We were trying not to use the word disorder, but I'm finding with a lot of the people that I'm helping through intimate partner violence that we have many, many symptoms of a TBI, and also TMJ. But only in some we're looking at like a Lefort fracture. A Lefort fracture is a horizontal fracture that dislocates the upper jaw from the skull. I'm sorry.
No, that's a great question. So yes, they would have been included, those maxillofacial surgeons. There also is a bit of a literature in dentistry, a bit of an IPV literature in dentistry, and I'm wondering if that has better numbers. I was a bit surprised about the dentistry literature. I don't know if they talk specifically about TMJ type problems as opposed to fractures.
Yes, because sometimes when you have the asphyxiation, you can, in trying to escape, you can dislocate the position of the TMJ joint, and then you have the pain and you have the headaches and you have all of the other symptoms. Thank you.
Yeah, I do want to say there is quite an extensive literature on IPV and dentistry. None of it, I don't believe, makes the link with brain injury, but as far as I can tell, but this is something that is in that literature. So the maxillary surgeons who tend to have a background in dentistry would be a good group, I would imagine, to collaborate with as well.
Thank you. I think that one of the questions that's asked when you're going to the dentist is, are you safe in the home? First question. Because now even taking the blood pressure, or just ask, are you safe in your home? And to think about asking that in a dentist's office, it's just a little bit different for some people. Thank you. These are amazing, beautiful presentations. Thank you.
Yeah, I agree. So is anything being done to address judgment and bias patients' experience from many doctors and nurses when they are forthcoming with IPV history?
And Linda Locke is spearheading this in New Jersey if she wants to jump on.
I'm sorry, Ed, can you repeat the question?
Is anything, it's in the
Doing two
chat,
things at once.
is anything being done about patients, what they experience from many doctors and nurses when they are forthcoming IPV history in terms of judgment?
So we're beginning to address this in New Jersey. I have an organization, New Jersey Health Cares, about domestic and sexual violence, which is specifically directed at healthcare providers and begins to have the conversation about how this might affect not only their intersection with the healthcare system, but how they respond to a variety of healthcare situations, including their ability to follow through on recommendations for care, and so we're just getting it out there, but it's something that we're working on.
Hi, this is Rachel. Is it okay if I pop in? This is
Hey,
Rachel.
Rachel.
I'm sorry I'm late. I had a earlier meeting that I couldn't get out of, but I did want to say we're doing some work here in Ohio. So I'm Rachel. I work with the Ohio Domestic Violence Network in the barriers around really people who don't ever want to go to a doctor again because of how they were treated or what happened when they disclosed abuse are very, very, very real. And I think something that we're actually learning, as much as it's important to ask direct questions about domestic violence, some of those questions is, as you said, are you safe at home? We're also really kind of the domestic violence field is somewhat pivoting towards, and I don't know, maybe not pivoting towards, but also including kind of more of a universal education approach. There are lots and lots of reasons why domestic violence victims don't disclose abuse. And, one of the challenges around when we're screening for domestic violence, and if somebody says, yes, I'm safe at home, they don't get any additional information. So again, like, you know, if you say like, no, I don't have high blood pressure, we're not going to continue into that kind of that area, but having information available to in clinics, having educational materials available, having posters, you know, having opportunities for people to just be able to get some information about that without need to disclose abuse is also really a strategy that I know kind of the leaders in the kind of healthcare and domestic violence field are pushing. So, you know, I just would encourage people to also think about just the power of having materials and resources that are available that people can take. I think the other thing that we know about when discussing domestic violence in healthcare settings, that sometimes it is, a lot of times it's a one-time question that's asked once right at the beginning when you see a provider, but
Right.
continuing to have those conversations. And it really is about kind of creating a situation of trust and safety where people feel comfortable disclosing that, because there's lots of real risks that are involved with that. So I just did want to throw that out there. But yeah, I mean, we have talked to survivors who have been very hesitant to go get medical care, to disclose abuse, to disclose head injuries, you know, have been told that no, your symptoms are not related to you being hit in the head. Just that is very, very common, and is a significant barrier that we need to tackle when doing this work.
I think, sorry, Linda.
Yeah, no worries. Thanks, Rachel. It's good to see you. And Catherine made me put myself on the video. So Planned Parenthood also has initiated that universal education and information approach during the pandemic, with what they suggest to put up, because a lot of times there'll be something on screen when you're doing telehealth, you know, to be able to put that information up so that it's available for everybody, saying, you know, we're just not necessarily, you know, even though your question may be no, you may know somebody who can utilize this information and you can jot it down. And having that universal information approach is really be very helpful.
I'd like to just make a comment real quickly from Paul and Karen's video on YouTube. We're up to about 90 videos, and some of the comments are just so telling. And this was a comment, so it's a public comment 2 weeks ago that came in and said, finding the pink support group was fantastic. My biggest stumbling block is how to talk to my GP. I think many women with ABI are dealing with mental conditions as well as traumatic experiences, not just the way they're treated by, also in just the way they're treated by police or with a brain injury, and they're not drunk or on drugs or dealing correctly and can cause more trauma. And she writes, a police officer was taking pictures of my neck. I was alone with him in a dark room. He used a flash and I was in a bad way. He said to me, joking in a jock way, those, meaning the bruises on her neck from somebody's hands, look like hickeys. Are you sure he strangled you? They look like hickeys to me.
Yeah, I've heard that from survivors too, about having marks on their neck and having comments made about them being hickeys. I've heard that from several survivors.
I think one of the things that really surprised me was that someone would come into the emergency room because of something like superficial injury related to IPV, and that the TBI part got completely overlooked. So, you know, hearing people say, I was knocked unconscious. I told the doctor I was knocked unconscious. I told my family doctor I was knocked unconscious. But all of my cognitive challenges are being attributed to PTSD or, you know, stress or the relationship. And the fact that this biological variable is staring everyone in the face, and still people didn't really ask about it.
Linda, what kind of response are you getting from New Jersey and reaching out to providers? And are you doing that pamphlet, email, video, webinar? What's the best way you've found to reach out to providers to get this information out?
Well, you know, pre-pandemic, it was primarily in-person presentations, which allowed for a lot of really rich discussion. I was doing presentations with residents, surgical residents in a variety of fields, and as well as nurses and OBGYNs and folks. And, you know, it really kind of depends. Now we're hopefully getting back to a little bit more of in-person, so we can have those discussions over the past couple of years, it's been primarily through webinars.
Katherine, and Angela, can I ask a question of the group?
Yes, it's probably the last question of the session
Quick.
to wrap up.
It's a real, and actually people could email after if they wanted. I'm curious, when we do all this identification, if people do find that there are resources in their community for people to get rehabilitation. Because we're seeing that as a big gap. So it's fine. You can say, yes, your cognitive problems are from IPV and TBI, but then we don't know where to send them.
I think especially if woman versus man, and then person of color versus a person with white skin. I think that the choices limit with insurance and socioeconomic and race, and absolutely. I mean, that's what we find with the women that come up on our support groups, that, you know, can you find me a pro bono neurologist, a pro bono lawyer, and a pro bono neuropsychologist? You know, and that's where we struggle as an organization, is to help with resources. Interested in what anyone else says in the last couple minutes?
Yeah, I just wanted to mention in response to Lyn's question, it's exactly that. There are these huge gaps. So as part of our project, we're doing a pilot intervention that incorporates kind of quite a bit of the complexity around the different components of the intersection between IPV and brain injury. But, you know, it's totally grant funded and limited number of participants, just as a proof of principle at this stage. But yeah, the goal would be to help fill that gap by informing some of the supports that are provided.
I just want to say that out in Cridge Center for the Family, they have an IPV TBI program that's relatively new. And also in Toronto, we have, like, our brain injury associations have, you know, increasingly in Ontario, we're seeing some really focused IPV TBI kind of programs that include peer support. So it's getting better, but I think there is a huge, enormous gap. And the Brain Injury Association of Ontario now has a compassionate, I think, reserve fund.
Compassionate Justice Fund.
Justice Fund. It was, I guess, Catherine Wiseman Hicks. We both share this former graduate student, and she's took a leadership role in that, and that provides funds that survivors can apply to, and to get healthcare and rehab. And it's my understanding it's been mostly IPV survivors with brain injury at this point. Okay, well, it's 3:02, and just we've gone over our time, and just kind of an indicator of the quality of the discussion and the great talks. So I want to thank everyone for coming, and again, for Katherine and her leadership. And so thank you very much.
Thank you to all the presenters today. And I did put the link, if you got this email, if you got the link to join us today through somebody else, or it wasn't addressed to you, that means we don't have your email. We literally only send emails out at right before our meeting. So I put the link in the chat, and it's also on the Pink Concussions website, and it says task force and join. So everybody's welcome to join, and everyone, thank you for your attention and time today.